Good evening and welcome to our 40th anniversary season premiere of Doctors on Call. I'm Dr. Ray Christensen, faculty member at the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus. I'm also a family physician at the 8-Way in Moose Lake, Minnesota. I'm your host for this season premiere tonight on COVID-19 and the Delta variant. This season we will again be rotating hosts from the medical school. The hosts will include Dr. Mary Owen and Dr. Peter Nalen and myself. The success of this program is dependent on you, the viewer, so please call in your questions tonight or email them to ask@wdse.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening are Dr. Christopher Delp, an emergency physician at St. Luke's Hospital, and Dr. A.J. Hegg, an emergency physician with Essentia Health. Our medical students answering the phones tonight are Abby Coyle from Watertown, Minnesota, Holly Olson from Cameron, Wisconsin, and Lindsay Simonson from Owatonna, Minnesota. And now on to tonight's program, COVID-19 and the Delta variant, and season 40 of Doctors on Call. Gentlemen, welcome. It's interesting as I sat and thought about this show tonight. We've looked at COVID in many ways. We've had several COVID programs, as you know, but you both are in the area where you face COVID head on. In the primary care clinics, basically we're screening and we're moving them to the ERs. And AJ, you work in an ICU and both of you work in the emergency room, so you get to see it from there. So AJ, do you want to introduce yourself and tell us a little bit about your work?
Sure. Hi, I'm AJ Hegg. I'm a board-certified physician in emergency medicine, internal medicine, and critical care. I work mostly in the intensive care unit, although I still work in the ER once in a while as well. So most of my patients, when they come to me with COVID, are patients who are needing to go on the ventilator or very close to going on the ventilator. And then we take care of patients until they are able to get off of the ventilator, which sometimes can be quite a long time in the ICU.
Chris?
So, hi, I'm Chris Delp. I'm the medical director for our stroke program at St. Luke's Hospital. I'm also the associate medical director for LifeLink 3 air medical transport system, as well as an attending emergency physician, and I've worked here in this community for about 26 years now, so it's been quite some time. So most of my time is spent working in the emergency department, seeing these patients kind of firsthand. And this has been a very unique part for all of our careers, I think. I don't think I've ever seen anything like this before, this particular outbreak, and it's impacted us in so many different ways. I'm just happy to be able to help a little bit.
And I'm many years out beyond you, and I haven't either. It's been a long time. Mm-hmm. It's my understanding in our discussions before we went on air tonight that the hospital system is being pretty much overwhelmed in Minnesota at the present time, and that hospital beds are hard to come by. What's it been like in your facilities?
So I'll start because usually the emergency department is just a short stop where we can either fix the problem or admit the patient for further treatment. And now it's become a place where we have to hold people for long periods of time because there's just no place to put them. All of our beds are full. We try to make arrangements for transporting these people to other facilities, but at the same time, all over the state, they're trying to transport patients as well. So it's really a scramble to try to get beds to take care of these people. And we're having to hold people for sometimes long periods of time, which further log jams the emergency department.
Yeah, and I see very similar things when I'm working in the emergency department, trying to get people in to be able to be cared for as an inpatient. It's really challenging, and we are taking care of patients for long periods of time there. On the other side, in the ICU, we have our beds are full. We're trying to take care of people as quickly as we can and trying to help people get better so we can get them out of the ICU because we know we have patients waiting. And we get calls from all over with patients who they're looking to transfer them to us, and we do our best, but it's hard to accommodate, and the entire state is trying to share the load. There's a system set up in the state to help emergency departments and hospitals figure out who has capacity, and that system is frequently overwhelmed or on the brink of being overwhelmed, at almost any given moment too.
As an older physician and being able to sit back in the private practice part of the world, I'm very indebted to you and those of you that are on the front line, and especially to the nursing staff and the people that are with these patients, taking care of the COVID patients all the time. How are our staffs holding up? Nursing staff, physician staff, health provider staffs?
This has been a really challenging couple of years, and my hat's off to all of the nursing staff, all of the respiratory therapists, all of the staff in our hospitals. They are just digging in and doing everything that they can to take care of patients. But I can't sit here and say that it has not been extremely straining on them. It's been hard, difficult conditions, just physically when you're in the room with a COVID patient and you're dressed in all of this PPE to keep you protected and masks, and we have these large machines in the room that keep negative airflow to protect them. You can't hear anything. It's loud, it's hot, and it's physically demanding. And this goes, day in and day out. That the nursing staff, the everyone there is just working hard, and it's taxing. And I think it's taken its toll on a lot of people.
What's it like being a patient in that situation?
The patients. So my patients in the ICU, most of them are sedated on ventilators. And so a lot of times they probably aren't as aware about it. If they are not sedated on ventilators, and they're trying to talk to us, then it's challenging because you have all this noise, all these machines, they can't hear, you're trying to talk through masks, and patients are in a situation that's incredibly scary for them, and incredibly stressful. And the physical environment around it is making it even harder for them to communicate and be heard.
It also impacts people that don't have COVID, because in the emergency department we're experiencing very long wait times. These are people that are sitting in there waiting to be seen for sometimes hours and hours, waiting just to have their lacerations repaired, because we're just so jam-packed with COVID patients. So that makes it challenging for everyone being a patient in this time.
One of the other things that we had talked about earlier before we came on was the air transport system, and you're a co-director. Do you want to talk about how that's working?
So the big problem with aeromedical transport in this COVID era is that to transport patients in a closed area, they had to be put on a ventilator in order to contain the virus. And we all know that putting people on a ventilator sometimes impacts their outcome negatively, because we can't really clean the cockpit with UV light or some of the detergents needed to clean that. So instead, here in Minnesota, the LifeLink system used the C-Long helmet, which is a special helmet to contain the virus. So we were able to transport the patient and help support their ventilation and still contain the virus and provide a safe environment for both the patient and the crew.
How's it working in the ambulances?
The ambulances are strained. They're a little bit more able to clean their rigs using the normal kind of virucidal agents. The aeromedical transport is much more tightly regulated in terms of those kind of transport issues.
And that first responder EMS system is another front line that faces it right up front.
Yes.
And the fire departments too, all of them.
Yeah, from the police all the way through. These are all people that they're used to putting their lives on the line, but for the first part of this pandemic, there was so many unknowns. They were putting themselves at a risk that they didn't even really know, and that none of us understood.
Vaccination. So, thank you for this background. I think it's a good background for all of us to know. I have a call from a person who had both Moderna vaccinations early in 2021, and then a breakthrough case in August. Does she need to wear a mask still? And I don't know if this is going to fall in your skills or not, so you can dump the question too if you want to.
I mean, I think it's hard, and it's hard to know what the right answer is. But I think, having 2 Moderna vaccinations, having COVID, certainly that sets you up to have antibodies and decreases your risk of future infections. But at the same time, if you do get COVID again, it may be less symptomatic or asymptomatic, and so masks still help prevent the spread of COVID. And so whether you've been vaccinated, whether you've had COVID or not, I think the moment that we are in with continuously rising cases in the state of Minnesota, cases, the whole region, we are having increased COVID. I think the smart thing is to wear a mask.
There's so many unknowns, and the bottom line is you're helping out other people, and so why would you not wear a mask and help out other people and help protect them?
Agreed. And it's also interesting that this is a pandemic with a new illness that we don't know anything about, and we are learning as we go. It's in the past, all of us, when we wanted to know something about a disease, you go to the books and you look it up or go online or whatever. You can't do it with this one. It's
Right.
just not, because it's not there. And we don't know the long-term effects either of COVID. And I would say another reason to wear a mask is you don't want to get it because we don't know what 10 years from now is going to be like with COVID, or 20. We just don't know those pieces yet.
Mm-hmm.
Can I get a COVID vaccination if I'm pregnant? And if I do, what are the risks?
Yes, they've approved it for pregnancy, and as a matter of fact, the risks are much greater by not getting it, and much greater for both the patient as well as the baby. And this is something that we look at very, very hard with multiple studies, with a lot of people, because these are complex issues. And the last thing we want to do is add additional risk in an already risk-prone disease. And so these studies have been looked at, done by multiple centers to firmly establish that safety.
Yeah, and I completely agree. I mean, everything that we've looked at, it is safe. It is safe in pregnancy. The patients who are getting hospitalized with problems and the pregnant patients that are getting hospitalized with problems are the ones who get COVID, not the ones who are getting the vaccine.
And that's everything I read agrees with what you're saying. The other question is, does it transmit some protection to the baby? When you, at least for a while, and I don't know the answer to that one.
We certainly know that the maternal antibodies do with breastfeeding. Those are passed on to the baby, so there should be an element of protection for the child as well.
So let's talk about Delta. Delta is kind of new this past several months that it's been around. What are you seeing? Are you seeing mostly just COVID, or are you seeing Delta also?
So what we do is we randomly send samples to get a sampling of which people have Delta and which don't. And at least for me, I never get those results to know if that particular person has Delta or not, but more of a surveillance. We're more doing surveillance and then extrapolating that data.
Yeah, and if you look at that surveillance data, I mean, I don't get it on a particular patient either, but overwhelmingly, we are seeing a lot of Delta. And I can say that there's a big difference in the cases that we are seeing now versus what we saw in the ICU in November, December of last year at the height of our large surge. We have a lot of patients who are a lot younger, who don't have as many comorbidities, patients as young as in their 20s, patients in their 30s, 40s, 50s. And the first time around, we didn't see that as much. If you were healthy and young, you tended to stay out of the ICU. But that is not what we're seeing now. We are seeing a lot more aggressive virus.
So as you bring up a year ago, and you've been through this, both of you have been through it, what things are we doing now that might be helpful in treating COVID? There's a lot of talk about what's the worming pill that goes to the animals and
the
all this.
ivermectin, yes.
Yeah, that's the one. Help me out here.
So, like a lot of things, there is some grain of truth in how these things got started, because early on, we were all looking for anything to try to help these patients. And there was some studies that were done, and we looked at ivermectin to see that might be helpful. There was some theoretical evidence that might be helpful, and there was actually some published data. The American Journal of Therapeutics is one that you commonly see quoted, in which they did a meta-analysis of all of these studies that showed that ivermectin was beneficial. The problem with that is that it took a lot of very badly done studies, and if you combine a bunch of very badly done studies, you don't get a great study. So the subsequent studies that were done on these showed that ivermectin wasn't nearly as beneficial and maybe harmful as well. And there's still ongoing studies. So we're not done with that yet. This data is being looked at time and again, and these studies are being redone to see if there's some benefit that may be gotten from that. But right now, the best done studies show that it just doesn't, it's not helpful.
Yeah, and I mean, I couldn't agree more. Ivermectin, we've been trying to follow the evidence, and we have all looked for whatever we thought could help. You know, early on in this pandemic, we were prescribing hydroxychloroquine. You know, when ivermectin studies came out, we all said, let's look at them. We've been interested to see if there's any signal there, but the data has not shown that ivermectin is helpful. And what we do have is we have a lot of data on things that are really helpful. Number one, vaccines. Vaccines are the most important and most helpful thing that you can do. If you get COVID and you're early on in your symptoms and you don't have to be hospitalized, the monoclonal antibodies will help you from getting hospitalized. If you get into the hospital and you need oxygen, then we put patients on steroids. Dexamethasone is the mainstay of what we use. And we have a couple of other medications that are immune suppressants. One of them is called tocilizumab. One of them is called baricitinib. We use those pretty frequently too. We were looking at a medication called remdesivir. A lot of people used it for quite a while. The literature isn't really bearing out that it has a lot of mortality benefit. And so that's a little bit more of a gray area if it's helpful or not. I think a lot of people are starting to think it's not helpful anymore. But vaccination is the number one. And then it's, you know, do those monoclonal antibodies if you can. And if you're in the hospital, we have medications that are definitely helping and improving mortality.
So we've seen these medications have been helpful in decreasing the death rate and making it so that people can live longer and come out of this in a better shape.
Yeah.
The other thing that kind of hangs out there is the long hauler syndrome, and people just don't get over these illnesses. How's that going? Especially as of course, you don't get to see them in follow-up, do you? You send them home and...
I don't see them in follow-up. I do hear about them from some of my colleagues in clinics, you know, as they go to pulmonary clinic, as they go to cardiology clinic. But I mean, it's interesting. I mean, we've had patients who have been in the ICU for 90 days, you know, in the hospital for even longer. And so these long haul symptoms, I mean, patients who get to the level of the ICU, you are going to have symptoms for a long time. What is that going to look like in 2, 3, 4, 5 years? I don't think we know, but this takes a toll on you. It is, it's a long and chronic disease after you get better even.
And it appears that at least the first round, us older guys, overweight, all the other things that were against us, made it a lot more of a risk to get COVID. Now with the Delta, that's changed a little bit, and more of the young people?
I don't think it's more the young people. I think that we are seeing more young people than the first wave, and I think your comments bear that out. But the first wave, so many affected disproportionately the older people, but then the ones that got over it, then that virus moved on. So we are seeing just a disproportionate amount, but it still hits the elderly. The Delta variant still hits the elderly and those people at risk very hard as well.
But the other thing is that was the group that got most vaccinated, and therefore has the most protection. And so part of us not seeing younger patients it is the group with less vaccines right now.
Are kids at a lower risk of contacting COVID-19 compared to adults?
Yeah, go ahead.
I mean, it seemed like in the first round there was a lot less children, but it seems like with Delta, kids are getting COVID more often. Kids are still young and healthy and they tend to do really well, but there are certainly some kids that are getting very sick from this. There are kids that are being hospitalized. And so, I think that we should be doing everything we can to protect our kids. The biggest thing goes back to everyone who can get a vaccine should do it, and that just decreases the virus in the population, and that's how we'll protect our kids best.
And wear a mask.
And wear a mask, absolutely.
Is there a difference in accuracy in getting tested at the DEC versus a physician clinic or your hospitals?
Each test has its own individual accuracy amounts. They're all, I think, very accurate, but each we study and look at a variety of different tests and their accuracies. I think in general, you can depend on the results. Trying to compare one with the other, I think, is very difficult.
I think the one thing caveat I'd say is if you get these at-home rapid tests, and you can buy them at CVS now, those are pretty good, but they're not as sensitive as the tests that we send in for PCR testing. And so they will give you some false negatives sometimes, and I think you should be cautious that that is not a perfect test.
The PCR is the gold standard right now.
Yeah.
When is it recommended to get a booster of the vaccine if tested positive about a week ago? I don't know the answer to that one. I don't know if there is one.
So the question is somebody who has COVID and now they're wondering when they should get the booster?
When is it recommended to get a booster of the vaccine if you tested positive about a week ago?
I think as soon as you have recovered from your COVID, and I would, if it is a mild case of COVID, 2 or 3 weeks. If you are recovered, then do it.
If I'm vaccinated and my friend is too also, do I need to wear a mask when I visit them indoors?
So the CDC has gotten guidelines for that, and some of that depends on if you're symptomatic. We certainly look at families that have been vaccinated, husbands and wives and friends, in small gatherings. If you're not symptomatic and the people are vaccinated, I think the CDC says that if it's small gatherings and among vaccinated individuals, that's still okay unless you're symptomatic, because again, we have all of these breakthrough infections that are occurring in vaccinated people.
And the tough part is that you shed for 2 or 3 days before we know that you have any symptoms.
Yeah.
AJ, anything to add to that one?
I mean, I agree, but we live in a world where nothing with this is 100% safe. We can't say this is what you're going to do and this is what you're going to be safe, but we can say what you can do to be safer. But I think, if you're with your family and a small group of friends, I think it is reasonable, and people are vaccinated, to not have masks. If you go out in public or in larger settings, then put it on.
Masks or viruses are very small. How can a mask with little holes in it keep from letting the virus through to you? How does the mask work?
So the virus is transmitted both in large droplets and small droplets. The mask is going to decrease those. And I would encourage you, if people really want to see this, New England Journal had an amazing video where they show somebody and they put a mask on and they show particles coming out. They use a laser to do this and show it with and without. And it's really obvious. It decreases what you are putting out in the air.
And the flow is 20 feet, not 6.
Yeah.
6 is too close. And then there's different types of masks also.
Yeah.
If we don't know the behavior of the Delta variant, how will we make a vaccine?
So I'm not sure the premise of their question, but the vaccines that we currently have will protect against the Delta variant, and I think that it's very clear that it is protective against the Delta variant, and they're currently doing surveillance or the viruses that may or may not evade the vaccine, and they do that kind of surveillance just in case there is any that emerge that will evade the vaccine, and then the companies will be able to, now that they've ramped up, to alter the vaccine to cover those in a much more rapid fashion.
The third Pfizer shot, how long to wait before getting the flu shot? I wanted to ask that when we've got about a minute left.
I got my flu shot 1 week after my third Pfizer shot. So I would have done it on the same day, but they didn't have it.
And I got mine both on the same day.
Yeah, I think that's probably better. And what I read was at least 2 weeks. So there's some various discussion on that.
Yeah.
Any final things that you gentlemen want to say?
Go ahead.
Yeah, I just, the vaccine, there's worries about side effects. Those side effects are so rare, and when you compare that to the mortality of the virus itself, that the vaccine, I just want to encourage people who are hesitant to just ask questions.
He speaks for all three of us. I want to thank our panelists, Dr. Christopher Delp, Dr. Aaron Hegg, and our medical student volunteers, Abby Coyle, Holly Olson, and Lindsay Simonson. Please join me next week for a program on women's health and female cancers, when my panelists will be Dr. Michael Cassing and Dr. Verna Thornton. Thank you so much for watching tonight. Have a great night.